All right, the last section of this chapter deals with lower urinary tract carcinoma. So the lower urinary tract includes the renal pelvis, the ureter, the bladder, and the urethra. And there are three types of cancers that classically arise from this location. The first is urothelial carcinoma, the second is squamous cell carcinoma, and the third is adenocarcinoma. Now, as far as urothelial carcinoma is concerned, this is a malignant tumor that arises from the urothelial lining of the lower urinary tract, so the pelvis, the ureter, the bladder, or the urethra. Now remember that the normal lining of the entire lower urinary tract is actually urothelial, and so therefore this is the most common type of lower urinary tract cancer. The most common location within the lower tract is going to be the bladder. The number one risk factor for urothelial carcinoma is cigarette smoke. In particular, within cigarette smoke, polycyclic aromatic hydrocarbons. Additionally, naphthylamine is a risk factor. Naphthylamine actually is one of the carcinogens present in cigarette smoke, and so therefore it's just a further reminder that cigarette smoke is a major risk factor. Azo dyes are an important risk factor. These are used for coloring. For example, there was a study which showed that there was an increased incidence of urothelial carcinoma in hairdressers in Los Angeles, and of course hairdressers were using dyes to color the hair of their clients. And so azo dyes increases the risk as well. And then finally, long-term cyclophosphamide can increase the risk for urothelial carcinoma, as can phenacetin. And so these are two important high-yield associations to be aware of as well. Urothelial carcinoma is generally seen in older adults. The classic presentation is painless hematuria, and it's important to note that it arises via two distinct pathways, and this is particularly high yield. In the papillary pathway, tumors develop as papillary growths, and remember that a papillary growth is essentially a fibrovascular core with a blood vessel running through it upon which epithelium is placed. And so this would be the papillary pattern of urothelial carcinoma. Now, important to note that in the papillary pathway, the tumors start as low grade and then progress to high grade, and then eventually they invade. And so this is the classic progression of the papillary pathway. The second pathway is called the flat pathway, and in this particular pathway you develop high-grade urothelial carcinoma that develops as a flat lesion. Now, important to note that this tumor does not start low-grade, but starts as a high-grade tumor that eventually progresses to invade. So again, the papillary pathway begins as a low-grade tumor that progresses to high-grade and then invades, and the flat pathway begins as high-grade and then eventually invades. Another important thing to note about the flat pathway is that it is associated with early p53 mutations, and that is particularly high yield. Again, early p53 mutations in the flat pathway. Here's an image of the flat pathway, and you can clearly see here's a lamina propria, this epithelium is sitting on a basement membrane, and that this lesion appears flat but high grade. And here's a picture of the papillary pathway where you can clearly see that you've got these blood vessels with fibrous tissues sitting in the middle of these finger-like projections. Here's a classic picture of a finger-like projection. And again, this papillary pathway begins as low grade, then eventually progresses to high grade, and then eventually invades. Now, patients who develop urothelial carcinoma often have multifocal tumors and often show recurrence. And the reason is that the entire urothelial surface is actually mutated in a phenomenon known as the field defect. Now here the idea is that the entire urothelium has been hit with carcinogens over a long period of time, especially in a person who smokes, and so the entire field, all of the urothelial surface, is essentially mutated, and it's only a matter of time before multiple tumors develop. And so patients often have multiple tumors, and they often have recurrence because there are so many mutations lining the surface of that urothelium. Again, that's called a field defect. The second type of tumor that can arise from the lower urinary tract is squamous cell carcinoma. Of course, this is a malignant proliferation of squamous cells, and it usually involves the bladder. Now remember that the lower urinary tract does not normally have any squamous epithelium, and therefore, in order to form a squamous cell carcinoma, you must first develop squamous metaplasia. Of course, that metaplasia would eventually become dysplasia, and the dysplasia would eventually become squamous cell carcinoma. The key risk factors for squamous cell carcinoma are chronic cystitis. Chronic inflammation can result in squamous metaplasia, which can then eventually progress to cancer. One very high yield risk factor is schistosoma hematobium infection. This is classically seen in the Middle East, and on board exams is classically seen in a Middle Eastern male, particularly a young Middle Eastern male. And so what happens in this particular case is that the schistosoma hematobium embeds itself within the bladder wall. That results in chronic inflammation, and again, that chronic inflammation results in a squamous metaplasia, which then eventually progresses to squamous cell carcinoma. Another risk factor would be long-standing nephrolithiasis. And again, the same idea here is that with a chronic irritation of the urothelium, you develop a squamous metaplasia, and the squamous metaplasia eventually becomes cancer. The third type of lower urinary tract carcinoma is adenocarcinoma. This is, of course, a malignant proliferation of glands, and it usually involves the bladder. Now, it's important to note that you normally don't have glandular epithelium lining the bladder, and so therefore this is only going to arise in particular circumstances. One super high yield circumstance is that this can arise from a urachal remnant. Now, this is high yield because it ties back into embryology. So let's just remind ourselves that the urachus is a duct that connects the fetal bladder with the yolk sac, and of course it allows the bladder to drain waste into the yolk sac. And normally this would run from the dome of the bladder through the umbilical cord, and it is lined by glandular cells. If there's failure to involute the urachus such that there's a remnant, this remnant can actually then become adenocarcinoma. And it's important to note for board examination purposes that this adenocarcinoma would be present at the dome of the bladder. Again, high yield. Adenocarcinoma that arises from a urachal remnant would be present at the dome of the bladder. Another risk factor for the development of adenocarcinoma would be cystitis glandularis. This is where a patient has chronic inflammation of the bladder and gets a columnar metaplasia in response to that chronic inflammation. Of course, that columnar metaplasia could then become adenocarcinoma. Now, the final association with adenocarcinoma is bladder exstrophy. In bladder exstrophy, you get a congenital failure to form the caudal or the lower portion of the anterior abdominal and bladder walls. And when this occurs, this exposes the surface of the bladder to the outside world, which then increases the risk in the future of development of an adenocarcinoma. And that concludes both the section as well as the chapter.